morning again, distinguished audience and distinguished speakers. We have the pleasure to introduce two eminent speakers from a neighboring country to the north of the Mediterranean who share with us the same profile of hematological diseases, notably the thalassemia. According to Professor Aman al-Ishlawi, we have about 10% of carriers of thalassemic trait in Egypt, and more than 1,000 cases of thalassemia major every year. So I think the major problem of thalassemia is shared by all the Mediterranean region. Hematopoietic stem cell is a curable modality of thalassemia, and we are waiting to hear the future about this therapeutic modality from Professor Javier from Italy, and we have the pleasure to hear from him the future of hematopoietic stem cell transplantation in thalassemia patients.
Thank you, Ms. Chairman. Good morning, everyone. First of all, I would like to thank Professor English for inviting me to this meeting. It's always my great pleasure to meet you and to share our experience with you. I will review the current status of stem cell transplantation for thalassemia and the future directions. It has been estimated that more than 100,000 children worldwide are from each year of thalassemia. You can imagine that the total number of patients around the world. Thalassemias were originally aroused in tropical and subtropical regions, have now become worldwide due to human migration. This poses a serious challenge for the healthcare systems of young countries. We know that life transfusion and chelation have improved life expectancy of patients with thalassemia. But with increasing age, these same patients acquire new complications such as heart disease, liver disease, osteoporosis, and other important complications, leading to end-stage organ failure and premature deaths. The life expectancy of patients with thalassemia in high-income countries has improved significantly during the last 2 or 3 decades, but it is not the case in low-income countries where thalassemia is an endemic. As an example, in Iran, you can see that the median survival is only 35 and 30 years old. Thalassemia is a progressive disease, unfortunately, and this study has been published recently in British Journal of Hematology and analyzed the natural history of thalassemia intermediate in 120 untreated patients. And then you can see that with increasing age, many patients, and that's the majority of these patients, require such debilitating complications as extramedullary hematopoiesis, pulmonary hypertension, heart failure, osteoporosis, hyperthyroidism. Hematopoietic stem cell transplantation is the only modality that can cure thalassemia definitely, and a successful transplant prevents disease progression and consequences, as well as reverse disease sequelae, allowing patients who can turn alive. The history of thalassemia started with these 2 patients transplanted in Seattle and in Cairo at the same time by Professor Thomas and his team and by Professor Karen and his team. The patient transplanted in Seattle was a 14-month-old child who was given only 150 ml red blood cell transfusion. This patient is cured from thalassemia and is alive more than 30 years. The patient transplanted in Pisa was a nearly adult patient, adolescent, and he received a huge number of red blood cell transfusions, and this patient rejected his graft and remained alive with thalassemia. But was the first of extensive series of transplants for thalassemia performed in Cairo, which led to these results. the thalassemia survival among 900 patients with HL identical sibling transplantation, related transplantation done in Israel was 73% with a follow of more than 30 years. Between December 85 and December 89, 222 children with thalassemia were homogeneously treated with busulfan, cyclophosphamide conditional regimen, and multivariate analysis revealed three factors such as hepatomegaly per centimeter, liver fibrosis, and irregular chelation history. Each of them had a negative international survival. So on the basis of these factors, patients with thalassemia are categorized into three classes of risk. Cluster patients have none, cluster patients have one or two, and cluster patients have all risk factors. Cluster patients treated with this treatment protocol, later on called as Protocol 6, had a higher disease-free survival rate, while cluster patients treated with the same treatment protocol had unacceptably higher transplant-related mortality, mainly due to toxic complications. So it has been decided to reduce the dose of cyclophosphamide to overcome this complication in cluster patients. And between September 89 and April 97, cluster younger patients were treated with busulfan and cyclophosphamide 120-160. Such dose reduction of cyclophosphamide has improved survival of patients, cluster patients, but this improvement was paid with increased rejection probability from 12% with previous protocols and to 30% with current one. Underlying that the dose of cyclophosphamide is essential for long-lasting and sustained engraftment. Obviously, this result could not satisfy neither patient nor us. So in 1997, Professor Lucarelli has adopted a new approach for transplantation cluster patients aimed at reducing the hyperplastic bone marrow characteristics of these patients and gradually increasing the immunosuppression before conditioning regimen to avoid peritransplant drug toxicity. 45 days before transplantation, patients received hydroxyurea and azathioprine, and from day -17, they were given fludarabine for 5 days. Cluster younger patients were given busulfan and cyclophosphamide 160, while in adult patients the dose of cyclophosphamide was subsequently reduced to 90 mg per kg. Preliminary result of stem cell transplantation in cluster patients treated with this new treatment protocol showed higher disease-free survival rate and, most importantly, reduction of rejection probability and transplant-related mortality as compared to previous protocols. Adult patients had advanced phase of disease, with organ system dysfunction and are considered high-risk patients for transplantation. And between November 88 and September 96, we have treated 107 patients with busulfan cyclophosphamide conditioning regimen, and their disease-free survival was 62%. Unfortunately, they had higher mortality rates. Subsequently, when we have adapted a new transplant protocol for cluster patients and adult patients, we have treated 15 high-risk adult patients with this new treatment protocol, including 90 mg of cyclophosphamide. And although there was some improvement in disease-free survival and at 10 point reducing transplant-related mortality, these patients still have high transplant-related mortality. In 2003, we moved some physicians to and we established a new transplant center at the McTain Institute of Hematology. And these are the patients treated at EMA between 2004 and 2011. There you can see the number of patients in respective countries. This patient population was different from those who treated in Pizarro. They were ethnically very heterogeneous and were not regular transfused and chelated, and were highly sensitized due to receiving red blood cell transfusions without liquid admission filters, and therefore were at high risk of rejection as a result of sensitization to minor histocompatibility antigens. Accordingly, we have modified our transplant protocol to overcome this anticipated complication in this patient population Here you can see the contention regimen that we are using to treat this patient population. Busulfan is essential drug. The condition regimen used in condition regimen for patients with thalassemia and sickle cell anemia. The drug efficacy depends on exposure. Low exposure are associated with increased reduction probability and relapse rate, while high exposure with transplant-related mortality and more graft-versus-host disease. Therefore, maintaining the drug level within therapeutic window is essential for successful transplant outcome. We have conducted a therapeutic drug monitoring study on 71 children with thalassemia treated according weight-based intravenous bisulfite, and we targeted ASU range between 900 and 1,350 micromole. And we adjusted the dose if the AUC was outside of this range. And for dose adjustment, we used the targeted the ASU value of 1,125, which is the mean value of this range according to the formula provided by the manufacturer. We have realized that 1/3 of patients at dose on busulfan could not reach therapeutic window requiring dose adjustment. Most importantly, we realized that we found that the busulfan clearance after dose on busulfan was significantly higher than the subsequent day busulfan clearances, which was never reported in the literature and probably related to the characteristics of this patient population. As a result of these discrepancies between the first dose busulfan and subsequent day busulfan clearance, the patients after dose adjustment mainly required dose readjustment, mainly dose reduction, because the busulfan clearance was stabilized in the following days. So, on the basis of this data, we have adopted a new dose adjustment policy in patients with thalassemia. Now we targeted a lower range of exposure, which is 900 micromole instead of 1,125. This allows us to avoid the subsequent dose readjustment, mainly dose reducing. We have treated 20 patients belonging to class 1 with the protocol 26, protocol 6, and they had a higher risk-free survival rate with a low transplant-related mortality rejection probabilities. The results of transplantation cluster patients treated with the same protocol were slightly inferior due to graft-versus-host disease-related mortality. However, the rejection probability in class 2 patients is the same as in class 1 patient. We have treated 26 classifications according to protocol 26, and their risk of survival was 73% because they have some increased rejection probability of 16%, which led us to modify this treatment protocol for classifications. And in February 2007, we increased the dose of fludarabine in the conjugation phase, and added titrated to the condition regimen to increase cytoreductive potential of this condition regimen. Until now, we had treated 90 patients with modified treatment protocol, and we compared the result obtained in this patient with the original protocol 26. As you can see, the demographic characteristics of these patients were similar, and patients had severe iron overload. They were heavily pretreated with blood transfusions, and median liver fibrosis was 2, indicating that this patient population already had organ system dysfunction. As you can see, the cytoreductive potential of protocol 26 was significantly higher than original protocol 26, leading to improvement of chromatin engraftment in this patient population. In fact, the incidence of rejection was 16% with previous protocol, with original protocol 26, versus 0% with the current modified treatment protocol. This obviously translated into improved risk-free survival 84%, although the difference is not statistically significant due to small number of patients treated until now. patients, and we hope that the current treatment protocol will be adapted by other centers with expected high engraftment rate and improved survival. The incidence of acute graft-versus-host disease was 35%. It was 9% for grade 2 for acute graft-versus-host disease. And pediatric patients are different from adult patients, and they are those usually younger, receive rich bone marrow with a high number of stem cells. They also receive high number of CD3 positive lymphocytes, and they found that there is a close correlation between the number of lymphocytes given to the patient and the incidence of graft-versus-host disease, and using an interquartile point to establish threshold of lymphocytes above which the incidence of graft-versus-host disease was significantly increased. And now with these patients we treat with day 11 methotrexate to increase the incidence of rejection. The incidence of chronic GVHD was not high. The moderate form was 9%, fortunately severe form 3%. And by the way, only one patient now on immunosuppression, all other patients having chronic GVHD of immunosuppression. At the beginning of our activity in Rome, we have treated 5 patients with protocol 26 for adults, and 3 patients had rejected their graft. And since February 2007, we are using the modified treatment protocol also for adults, and 4 patients until now were given stem cell transplantations. All 4 patients had successful engraftment and cured from thalassemia. This is the modified treatment protocol for class 3 patients, the same as we use with younger patients, with the exception the dose of cyclophosphamide is low, 90 mg per kilogram. Graft rejection is an important complication of transplantation, and the incidence could be as high as 38% of patients with thalassemia if they are treated with standard treatment protocols. So the question was what to do with this patient population. Treat them with this from the same donor or leave them on conventional treatment. We have chosen the first choice, and our initial experience was not successful. 16 patients were given protocol 26 with increased dose of cyclophosphamide, but the rejection was very high and transplant-related visitor survival was low. So we decided to modify this protocol for second transplantation. We increased the dose fludarabine, added thiocapep and ATG to the conditioning regimen. In fact, these modifications were very successful. Now these patients treated from the same donor with second transplantation have 79% of visitor survival rate. As you can see, only 1 patient had rejected in this series, and indicating that this transplant protocol is highly effective in terms of cure for second transplantation. 15 patients have died. The major cause of this was acute and chronic GVHD, and the rejection followed by rejection and infectious complications. One of the major obstacles to a successful transplantation is the limited number of sibling donors and specific donors within families. In fact, between 25–30% of patients could have a sibling donor, and for those patients who lack a suitable donor, alternative source should be sought. Some 8–10% of patients could find phenotypically matched parents or relative donors, and another 10% of patients can have one antigen mismatched siblings or relatives within families. And now with current treatment protocol, we have a very success rate in this type of transplantations. And patients now, approximately 20–25% of patients could be successfully treated by unrelated donor transplantation. And few patients can receive well-selected cord blood transplantation. And patients not fulfilling this criteria, obviously, could be offered bilateral stem cell transplantation. This is the Italian capital group experience on the related BMT for thalassemia. 88 patients affected by thalassemia were treated on unrelated marrow transplantation. Donor recipients were identical for class 1 antigens, except for 15 patients who had some anomalous matches at class 1 loci. The disease-free survival for the entire group of patients was 70%, with mortality rate accounting for 19% and rejection 13%. But cluster patients treated on related marrow transplantation had excellent results. Their results are similar to those observed after sibling marrow transplantation. Fortunately, cluster patients were even with unrelated means they had high transplant-related mortality in this series. This group also had transplanted 20 other patients with unrelated marrow transplantation, and their disease-free survival was exactly the same as we observed after sibling marrow transplantation. And as in sibling BMT7, unrelated BMT, also even associated in adult high mortality rate. The incidence of acute and chronic GVHD after unrelated BMT was similar to those observed in sibling marrow transplantation due to perfect matching between donor and recipients. What is the best stem cell source for transplantation in patients with thalassemia? Recently, Dr. Locatelli and co-workers have analyzed the role of related cord blood transplantation in patients with sickle cell disease and thalassemia. And as you can see, all but 3 patients received matched sibling cord as a graft source, and this survival of patients with thalassemia was 79%, it was 90% with sickle cell disease. And they have demonstrated patients given not methotrexate including conditioning regimen as a prophylaxis for GVHD, and conditioning regimen not including cyclophosphamide produced high results, high disease-free survival. And importantly, the incidence of acute and chronic GVHD after cord-related cord blood transplantation was very low. Unfortunately, the graft failure rate was high, 21%, 4-fold higher than we observed using bone marrow grafts. Probably cell dose containing low surveillance cord blood is essential for sustaining engraftment. This study has analyzed the results of bladder transplantation versus peripheral blood stem cell transplantation. As you know, that around 70–80% transplantation are performed with peripheral blood stem cells, including adults and pediatric patients. And this study clearly demonstrated that the incidence of both acute and especially chronic GVHD was higher after peripheral blood stem cell transplantation, clearly indicating that peripheral blood stem cells using should be avoided for transplantation patients with thalassemia. The results of elevated cord blood transplantation in pediatric malignancies are similar to those after using unrelated marrow transplantation, and encouraged by this data, some transplant centers have performed unrelated cord blood transplantation in patients with sickle cell disease and thalassemia. And this registry-based study recently analyzed the results of unrelated cord blood transplantation in 51 patients with sickle cell disease and thalassemia. As you can see, the vast majority of patients received 1 or 2 antigen mismatched grafts, and the survival is extremely low, 21% for thalassemia and 50% for sickle cell disease. Although this study has demonstrated that stem cell dose is important for successful, for increased disease-free survival rate, even such patients in this series will have only 45% disease-free survival rate. This data clearly demonstrates that this kind of transplant should be performed in experienced centers, and mismatches beyond 1 antigen usually should be avoided. Interestingly, different results have been communicated from China. Recently, this study has analyzed the results of related cord blood transplantation in 25 Chinese patients who received mainly cord blood from Chinese donors, and most patients were given more than 1 antigen mismatched graft. And there, disease-free survival was 79%. Interestingly, the transplant-related mortality in this area was low, despite high incidence of acute and chronic GVHD. Probably genetic homogeneity in this Chinese population had influenced this result. What is the situation of stem cell transplantation worldwide? This is the EDMK hemoglobinopathy register data covering time frame between 81, 1981, and 2009. And you can see the number of transplantation performed transplanted thalassemia is increasing yearly. Eventually survival for the entire group of patients was 76%, exactly the same that we observed in PISA, which indicate that, show that, and PISA result is reproducible in another sentence. Here you can see the transplant pattern in some European and Middle East countries. You can see the Italian centers are more active transplantation of thalassemia. Ex-thalassemics after transplantation continue to have previous therapy-related complications, such as iron or hepatitis, cardiac disease, liver disease, growth disturbances, hypogonadism, delayed puberty, diabetes, osteoporosis. But they can also have interrelated complications such as chronic GVHD, growth disturbances, infertility, and malignancies. In this natural history of our study, we have demonstrated that cluster and cluster patients are not able to eliminate spontaneously excessive iron from their bodies, even 7 years after transplantation. In another natural history of liver fibrosis study, we demonstrated the high hepatic iron concentration and hepatitis A virus positivity are independent risk factors for liver fibrosis progression. So we have decided that excessive iron should be eliminated from ex-thalassemic bodies as soon as possible. We usually started this iron depletion program at 1 year of transplantation when the patient finishes immunosuppressive medication, and in the selected cases, we anticipate that 6 months of transplantation. And we have demonstrated the phlebotomist and desclorexamine successfully reduced until normalization of iron stored in these patients, and should be given to this patient population. Hepatitis is another important issue with thalassemics. In this kind of study, we have shown feasibility of interferon treatment of hepatitis in this patient population without interfering with the engraftment and graft-versus-host disease. And now this patient can benefit from a combined interferon and ribavirin treatment with expected high results of treatment. Group failure and endocrine dysfunction are common in thalassemic patients treated with conventional treatment, As we have shown that patients treated before 8 years of age had normal growth, whereas the majority of patients receiving transplant after 8 years of age failed to reach a final high. Most of the females and most of the male patients who received transplant during childhood or peripubertal period reach an advanced and complete spontaneous puberty despite evidence of hormonal dysfunction. Everything is clear that the age is an essential factor for transplantation going to transplant thalassemia or thalassemia. Fertility is another important issue related to thalassemics. We know that hormone failure is a common complication of this often conditioning regimen, containing regimen, especially in girls and in boys. And we have 15 ex-thalassemic children. 9 females had successful pregnancies, and 6 partners of 6 male patients delivered normal child. This data clearly indicated patients given to this cyclophosphamide regimen are not inevitably infertile, and if transplant is given before pubertal development, a lot of patients can recover fertility. BNT survivors can have some increased risk for post-transplant malignancies due to previous chemotherapy or radiation therapy. And the incidence of malignancies in ex-thalassemic was also high. It was 1.3%. We have observed 12 malignancies among 900 ex-thalassemics, and 6 patients died, 6 alive and well. One of the major problems of transplantation thalassemia is the excess of transplantation due to lack of private and government-funded insurance coverage, which limit complicate the transplantation to the patients. Fortunately, pharmacoeconomic data demonstrating the advantage of early definitive therapy for thalassemia versus lifelong supportive care can help improve coverage for stem cell transplantation, especially in countries where thalassemia is a common problem and they have limited resources. Another very important issue is the limited number of siblings among the families. And at this point, national donor registry should be urgently organized to enable physicians to offer national transplantation, not only for thalassemia patients, also for all international disease, especially hereditary diseases. And ongoing efforts to improve outcome for blood and upper dental transplantation of thalassemia may one day address this problem as well. Finally, we thank the patients and families for giving the opportunity to treat them and for medical and nursing technicians at our institution. Thank you for your attention.
Thank you very much, Professor Javid, for this very interesting topic. You have raised a lot of... you're going to ask a question? Oh, okay. And... okay, Professor Emeritus Shlewy will deliver an appreciative gift to Professor Javid.
Thank you very much, Dr. Javid, for coming and participating in our conference. And this is a very small cadeau to remember us and to remember our conference when you are back home. Thank you very much.
Thank you very much. Thank you. May I sit?
Thank you very much. And our next speaker in this Italian plenary session is Professor Marco Andriani, and his talk will be about presence of persistent mixed chimeras of the...
Once again, really, I'm very happy to be here, and it really feels like to be home again all the time that I'm here. I don't want to bother you with my talk. What I would really like is that we can share a story of mixed chimeras after transplantation in thalassemia. We have heard from Professor Garcia the very nice results that we get after treatment of patients with bone marrow transplantation, or generally talking with hematopoietic stem cell transplantation for thalassemia. But mixed chimerism is something that occurs in many of the patients, and as we will see through my presentation, I really hope that this will be just a take-home message and not just to, I don't want to get too much inside some of the aspects that we generally cover. You will know that a chimera is a strange animal with different parts of animals, of other animals. So a chimera, generally talking, who is after a transplantation, is that in the body of someone that is green, you get a different organ, and in particular the hematopoietic stem cells. And to monitor the engraftment of the donor cells is a very important issue, of course, and it could be also interesting, also not in thalassemia only, but also in other malignant hematological disease, to follow eventually the relapse that could happen. And there are whole bunches of different papers that has been currently publishing on this issue. But to monitor the engraftment means, of course, to monitor the possibility that in the engrafted cells you have both donor and recipient cells. So that's why this is no longer a chimera, but is in this case a mixed chimeras, where the coexistence of donor and recipient cells are really there. Thalassemia, for a certain point of view, is a very important and unique model for studying this because, as you all know, there is not the presence of malignant cells. So, in my talk, I will just give you some idea of these five different issues, how we detect the presence of mixed chimeras in our patient, the difference between transient and persistent mixed chimeras, that is in our mind, in our hands, and I hope after my talk will be clear to you, it's a completely different story. The detection of mixed chimeras in red blood cells, that is, and again, very important, in particular for thalassemia patients, the control of erythroid compartment expansion, and I will try to tell you at the end of my talk something about regulatory T cells and how the tolerance, immunological tolerance in our patients has been in some way established. So let's start with this first topic, that is the way in which we generally detect the chimeras. There are common markers like STR, FISH. This is just a picture to show you for FISH for Y and X chromosome in a sex mismatch transplant has been very useful, of course, because you can detect the two chromosomes. Generally, we use the STR that are just the repeating of non-coding DNA that is very easy to detect, and you can have different lengths in the fragments, and so you come out with differences between the pre-transplant and the donor. So in this case, you have band 16 and 17 in the patient, and in the donor you just have the 17 and 17. So after the transplant, you want to see this picture, and you would have 100% donor, of course. And this is what you want because you want a successful transplant, or this is just a different example in another system. But let's go to the issue of differences between transient and persistent mixed chimeras. Transient, when we were in Cairo, in almost 500 patients that we tested, we found that early after the transplant, 2 months after the transplant, more than 50% of the patients presented the characteristics of having mixed chimeras. And this was reproducible in the experience of Rome, as Dr. Gattier has just shown you. Many of the data that we obtained in Pesaro were really obtained also in Rome, in a different story. In transient mixed chimeras, it is important to know the number of residual cells present, the split chimeras between the T cells and the normal cells, and the conditioning regimen used. So let's stay on transient mixed chimeras. The number of the recipient cells present is very important. So if you have green the patient cells and red the donor cells, in this early after the transplant, this situation is very safe because mostly of the patient will go to complete chimerism. If you have a little bit more, you reduce the proportion of the patient that goes to complete chimerism, the proportion of rejection increases a little bit. But early after the transplant, you face a picture like that in which you have many recipient cells left there. The proportion of the rejection is really very high. And this is very consistent data, of course. And so, for example, in our experience, among 10 patients that early after the transplant showed mixed chimeras level 3, means with lots of recipient cells present, half of them rejected the transplant. So this is a very nice observation to take care once you make the transplant. On the contrary, among the 50 patients with complete chimeras, only one rejected the transplant. We have published this paper, of course. The presence of T cells, of split chimeras between T cells and whole blood cells is also important because sometimes you face a picture like that in which you think that you have a mixed chimeras with many donor cells, but if you look at the T cells, you can find a split chimerism. That means that the T cells are mostly of a recipient. And this is also a situation in which we can face higher rejection rate. Another very interesting observation was the fact that the transient mixed chimerism is conditioned by the conditioning regimen. As we have heard by Javid, this is the conditioning regimen that is mostly used, but in some setting of patients it has been reduced the proportion of cyclophosphamide going down to 160 and 120. Well, this reduction of conditioning regimens was correlated with an increasing of the presence of transient mixed chimerism again, early after the transplant. So, if you reduce the cyclophosphamide, you have a larger proportion of patients where the recipient cells are present. And of course, this is correlated to a higher rejection proportion, but not to a mixed chimerism that becomes persistent. So, all the patients that after having an experience of transient mixed chimerism early after the transplant developed a persistent mixed chimerism, they are still there. And these patients, this situation is a situation that we see after 24 months from the transplant, no longer early after the transplant. And in this, once persistent mixed chimerism is established, it's stable. It's really stable, so you do not face any graft evolution toward rejection or to complete chimerism. And the cells are there. And these patients are cured because they do not receive any red blood cells infusion. They have stable and high level of hemoglobins, and they are really they show what we call a functional graft, and they are cured. And in many cases, the proportion of the donor and recipient cells is very high. And the proportion of the patients that become persistent is about 10%. So about 10% of all the patients that were transplanted have shown a situation of persistent mixed chimerism after 2 years from the transplant, and longer from that moment, of course. And the very incredible thing that is something that I really want to share with you is the information that some of these patients has really a very low proportion of donor cells. So these patients, after 14 years of follow-up, has 25% of donor cells engrafted only. This is 29 after 5 years, 18% of donor cells, nucleated cells, 20%, 15% after 7 years. So these are really peculiar patients. And just to have an idea of what is the slope, they have, especially, it seems that they are going to reject the transplant, and they are not. And so this is a proportion of the donor cells. This is one of the patients. I want to share with you some of the examples of these. This is the second patient that starts with transient mixed chimerism that evolved. It seems that it's going to reject the transplant. It's not. And both in the bone marrow and in the peripheral blood, he has 20% of donor cells. And he's safe. He's cured. And these are other patients. And these patients have a normal subset distribution. They do not. They have a normal lymphocyte immune system. They respond to allogenic stimulation. They respond to. So if you look at the distribution of a subset distribution, mixed chimerism is present in all the lymphocyte subset that we observed. They are able to respond to polyclonal stimulation like PHA or other mitogens, and they are able to respond to allogenic stimulation too, or viral stimulation. So this is the situation. So the very first question after that we have many of these patients were, how are the red blood cells of these patients? Do they belong to the donor or to the recipient? Because they do not need any more blood transfusion. So what we knew because of course it's very important, and we have heard from one of the presentations this morning that there are settings of transplant in which you use HLA-compatible donors, but you don't care about the ABO incompatibility that actually in our hands do not make any disaster in the transplant. But, you know, in thalassemia patients, the function of the red blood cells is very crucial. So, if we take a look to some of these patients, and what we knew was that the synthesis, the hemoglobin synthesis was very high, but we didn't know if this was synthesized by the donor or the recipient cells. So, we investigated the red blood cells, taking advantage of the fact that some of these patients had ABO or other disparities in the red blood cells. So, for example, this patient, this donor was C baby E little, and the patient was C little and E big. So they had a disparity that could be used in order to follow the erythrocytes in the peripheral blood of these patients. And actually, the proportion of in the patient of the donor was very, very low. So if you look at here, the 80% of the red blood cells in this patient that had in the nucleated cells only 50% were almost all of donor origin, in not only one single documentation, but also the second one. So at this point, after almost 15 years from the transplant, this patient has 25% donor cells, nucleated donor cells, but in the periphery, the red blood cells are all of donor origin. And there are so many other thalassemia patients that transplanted as this situation. I'll show you some of them. And you can see in this plot that these are the proportion of red blood cells. So nevertheless, if they have very few engrafted cells, they produce lots of erythrocytes of donor origin. So we all know that thalassemia is a progressive disease. So if you imagine this like the bone marrow of a patient with thalassemia, you have a erythroid expansion. But in the settings that I've shown you, it's like if you have a very low proportion of donor cells that is able to control this, and the erythroid expansion is no longer present. So the question was, there is something that is going to control the erythroid expansion, because otherwise the red blood cells that are coming out from the marrow of the recipient should come out. So we took some experience, we made some experience. I don't have any answer of this, which I just can tell you that we showed, we studied the VFUE of these patients, and as you know, of course, the VFUE are very ancient colonies, precursors. We took the VFUE singularly from this patient, we extracted the DNA, and we observed the origin of these colonies. We wanted to know if within the different VFUE we had donor VFUE or recipient VFUE, because we were sure that they were all of donor origin, since the erythrocytes were of donor origin. But the answer is no. The answer is not. The proportion of the VFUE is exactly as the nucleated cells. So, and this is true in all the patients that we studied. So these are the red blood cells, almost all of donor origin. These are the nucleated cells that we're seeing. This is the proportion of VFUE that is exactly like this. So we really don't know what happens. We are trying to, I don't want to bother you with this, because we are trying to develop different experiments in which we are trying to differentiate these. But what is come out is that right now I do not have any answer, and I want to leave you with this curiosity that I hope in the next few months, if Professor Al-Beshladi would be so kind to invite me again in this beautiful place, I hope to have you some answer, because what we are doing now, we are trying to pick up the different erythroid precursors in the marrow of this patient with cocktail of monoclonal antibodies, so that we can pick up in a cytofluorimetry, in a flow cytofluorimetry, to pick up the different erythrocytes precursors, erythroblast, basophilic, and polychromatophilic, in order to see if they are prevalently of the donor or recipient origin. But because there must be a moment in which they become mature, and we will see. Actually, our very first experience do not seem that there are differences also in there, because they all have the same proportion of the nucleated cells. But we'll see, and we'll see in the future. What is clear anyway, and this is another take-home message, I'm sorry that Dr. Acuto is not here, but we were discussing yesterday this issue. This is a very important message for the people that is going to take care of gene therapy, because as Dr. Acuto showed you yesterday, no one, at least now, will be able to transfect so many cells in an autologous scenario in order to have a complete changing of cells that will be genetically treated. So the idea, the fact that in some patients you have few donor cells that are able to produce, to cure the disease, is a very important notion. I don't want to bother you so too long, but and I want to go too much in these details. But mixed chimerism, persistent mixed chimerism, is bound also to immunological tolerance. So we were asking, besides what happens in the marrow, that we actually do not know how to answer, what happens in the periphery? There is any an immunological fact that helps to maintain the donor and the recipient cells together without fighting. So this was the question. And so we were asking why some of these patients are going down, rejecting the transplant, and some of them instead actually looks like they are going to reject the transplant, but they are not, they recover. So this is what happens in many of our patients. So we were thinking that there could be in some of these patients the presence of T regulatory cells. But I want just to tell you something. We found many regulatory cells, and we wanted to know if the regulatory cells that were eventually there were of donor or recipient origin, and if they were able to really suppress in vitro the reaction between the donor and the recipient. So the regulatory T cells are regular cells that are being very popular in this period because they have been used and they have been studied, especially in solid organ transplantation. Don't forget that in solid organ transplantation now, especially for the work of Megan Sykes or David Sachs, in order to maintain the kidney transplant, in some patients, they transfuse the donor cells in the beginning after a very short and very limited conditioning regimen in order to have the presence of the mixed chimerism. After that, they transplant the kidney. And the proportion of the patient that accept the transplant, the allograft, is much higher. So, why? Because there are regulatory T cells. So, just to remember you that the regulatory T cells there are two different kinds of T regulatory cells. Mostly are CD4 cells. They can be the classical CD4, CD5 phosphate-free cells that I don't want to bother you with this, or can be the induced by IL-10. we studied these. These are the T regulatory type 1 that has been studied mostly in Milan in the laboratory of Professor Roncarolo. They are anergic, they are expansed if you treat them with IL-15. They do not express FOST3, but they can if you stimulate. They react to the granzyme B, and they suppress mainly through the production of IL-10 and TGF-beta. So, we went back to our patients, the one that had a lot of, very few donor cells engrafted in the nucleated cells, with red blood cells, all of donor origin, and we cloned some of these cells. We took the CD4 cells, we cloned them, and we came out with some clones that were there. And we classified this clone based on the characteristic, and the T regulatory cells have this characteristic. They produce little IL-4, a lot of IL-10. And based on these, we can see, we could detect in our patient, this is a paper that we have published recently, that in two different clones, we really had lots of these T regulatory cells in these patients. And we wanted to know if they were of donor or recipient origin. And actually, they were both of donor, or the origin was both of donor and recipient. So they were there, all of them. And this was observed in many other patients. All the patients with persistent mixed chimerism that we have studied have lots of T regulatory cells, many more than what you generally observe in normal patients. But the goal question was, okay, we have a patient with persistent mixed chimerism, in which donor and recipient stay there. We know the red blood cells are of donor origin. We know that there are T regulatory cells present, and we know that the T regulatory cells are very important in order to maintain the graft, especially, as I was telling you, in the experience of the kidney transplant. But do these T peculiar regulatory cells are able to make something between the cells of the donor and the cells of the recipient? So we designed an experiment in which we put together the recipient and the donor cells in an alloreactive test. Don't forget that these are HLA compatible, related transplants, so they do not react generally very much. So we had to develop a system in which a very low production of something was detected by interferon gamma. And we added the T regulatory cells, the clones that we have developed and we have cultured. And actually the answer is yes. These cells, these T regulatory cells, specific for donor or recipient, were able to suppress the activity. So if you take the patient peripheral blood mononuclear cells and you add the host clones, some of these clones are able to suppress a lot the proliferation that you have. This is true also for the contrary. If you take the donor cells and you put the host cells, some of these clones are specifically able to inhibit the production of the proliferation of the two populations. So, and this is what I just tell you. There are lots of many studies that are currently running in our laboratory in conjunction with Milan San Raffaele Hospital. We want to know the role of the granzyme, and we want to define a genetic profile of these TR cells, because maybe that some of them are really peculiarly different from a genetic point of view and could be very important. And we want to make some functional studies of the dendritic cells, but this is a completely different story. So we are, I think that really we are at the beginning of this story. And the conclusion is that the tolerance in this patient is really well established, and the definition of this mechanism will be something that we have to do. Again, lots of people to be thanked because this work has been able to involve many different people, not only the clinician of the Tor Vergata Hospital, but also the group of Professor Roncarolo in Milan, and the transfusion study of the culturing, and of course my wonderful people of my lab in Rome. Thank you very much.
Thank you, Professor Andreani, for your very nice and comprehensive talk. I think before going on, we have time for just 2 questions for Professor Davis and Professor Andreani.
Thank you for your talk. Why not consider the preferential survival of normal red cells as an explanation for the difference in the percentage of donor red cells and the donor VFU?
So what do you mean? The fact that the recipient cells, well, the recipient cells are no longer there, what we think is that there could be. I didn't show you the data about the apoptosis because we are convinced that many of these recipient cells that are present in the marrow do not come to maturation because some of them go to apoptosis. But again, if you are not in a transplant setting, our patients unfortunately develop red cells that are carrying the DECA. So we are really not able to understand which is the difference between the 2 maturation lines from the donor and from the recipient.
Any other questions?
Can I benefit from being the chairman to ask a question?
Yes.
Yes, okay. I am fascinated with the immunological work on the mechanism of immune tolerance and keeping the donor cells within the blood and the bone marrow of the recipient. And I think it would be very important to characterize the genotype of the TR1 cells. I think this will help so much in the explanation of in the fight of the disease graft versus host disease infect. In malignancy and also in thalassemia patients.
Yeah, I totally agree with you. Not only for this, but also yesterday we were talking about the roles of different immunogenetic factors like manual-histocompatibility antigens, Q receptors. All these factors will contribute, may contribute, and I totally agree with you that the card, a genetic card that will be identifying a profile will be very, very helpful, and we are actually working on that. Thank you.
Professor,
thank you, Dr. Marco André, for this fascinating lecture. Actually, I would like to ask, what about mixed chimeras in haploidentical bone marrow transplantation?
Well, I didn't present the data of the mixed chimeras in haploidentical transplantation, but we have very few. The proportion of the mixed chimeras in the setting of haploidentical transplant is lower. We have a couple of them anyway. These patients face the transient mixed chimeras, some of them. The experience of haploidentical transplant is too young in order to make the proportion of make the same kind of observation as the other that I showed to you. But I can tell you that the proportion of patients transplanted from an haploidentical donor that developed persistent mixed chimeras will be very lower, much lower than the one that we have seen till now. But it will be no difference anyway.
Okay.
I'm sure that there will be no difference.
Thank you very much. And for Dr. David, because again, haploidentical bone marrow transplantation, what's new which can increase the tolerance and immunotolerance in haploidentical bone marrow transplantation, especially taking from the mother to the child, because many of our patients are looking for this type of transplantation, mother to the child.
Actually, there is a new transplant program regarding T-cell depletion in haploidentical stem cell transplantation. This experiment has been done in pediatric hematological malignancies. It names as gamma beta T-cell depletion with high risk, high success rate and low GVHD and high engraftment rate. We have an intention to adopt this treatment protocol and apply it in patients with thalassemia, but we haven't did it yet. Now our current policy is to change the policy adopting this treatment protocol. You know that haploidentical stem cell transplantation, even in children, has a big, with T-cell depletion that we are doing now, has a big problem, immune recovery. And post-transplant, you have an excellent engraftment. It doesn't mean the problem is finished. It is not as the sibling marrow transplantation, not as the unrelated bone marrow transplantation. They are have immune deficiency, frequent complications, and some increased mortality rate from I'm talking about the pediatric patient. In adults, the problem is much severe. For this reason, the policy should be changed, and probably will do it.
Okay, thank you.
I'm asking about early intervention strategies that we can apply if we face a transplanted patient with more than 25% of patient cells after transplantation. Is there a place if we can boost the graft or increasing the immune suppressive therapy to reduce the risk of graft, to reduce the risk of rejection after that?
Yeah, well, this is probably a question that you should address to Jalil. When we have a patient with mixed chimerism, the proportion of immune suppression is reduced. If the therapies that are currently used are probably already maximized in order to prevent rejection. There will be new drugs or new treatment, but again, this is a question that has nothing to do with mixed chimerism. This was our observation. So what I can tell you is that the patient will transit mixed chimerism as a higher proportion of rejection, but the treatment of this patient is up to Jalil.
The problem is that immunosuppression is not working. It is not working. We have made a study in this patient population, and we haven't seen that we measured the cyclosporin concentration in patients rejected, not rejected. There was not any difference. It means that even we increase subsequently, then for the patients not rejected and rejected have the same drug level, but some patients have rejected. It means that it doesn't work. The only problem to face this rejection is maybe donor lymphocyte infusion. The problem is that donor lymphocyte infusion is not working in thalassemia as well as in malignancy. The thalassemia is so fastly proliferating when the rejection starts, because of the mass of benign tumor that thalassemia. It is important. Okay? In some selected cases, it can work. They are very limited and anecdotal case report demonstrating that DLI could work if you intervene early. But DLI have another serious complications, you know. It is graft-versus-host disease, and the patient graft-versus-host disease related to DLI infusions is much aggressive and less responsive. So one thing, why I have to run risk? Run risk means we prefer that the thalassemic patient after rejection rehab his disease and remain alive. And give him a second possibility with second transplantation when there is accepted time, okay? Then to make some experimental approaches.
Can we give a boost for them?
Boost, what do you mean boost? Bone marrow?
Yeah.
No, they are alive. Bone marrow, yeah. But it depends on no. Boost is working when there is graft, malfunctioning graft. 100% donor engraftment, but cytopenia. In this case, BOS is working because you have donor engraftment. When in mixed chimerism, in progressive mixed chimerism, BOS is not working. We did it. We nothing obtained. We have left it.
Okay, at the end of this stimulating session, we have to thank the speakers and the audience, and you have a coffee break for 15 minutes.